right, welcome back everyone to the deep dive. We're going to be tackling a topic today, well, a few different topics really, all kind of related. And these can be tricky ones, I know, tricky to diagnose, and then even once you have a diagnosis, tricky to manage. I'm talking about orbital vascular tumors.
Yeah, definitely some unique challenges for ophthalmologists and not always super common, so you might not see these all the time in your practice.
Exactly, which is exactly why I think it's worth taking the time to do this deep dive and go over what our sources had to say about these different tumors.
Definitely. And, the idea here is to give you, listening, what you need to know, the things you really want to have in mind when you encounter these patients.
Yep, we'll focus on the practical stuff. So things like, how do you know what you're dealing with? What are the little red flags in terms of symptoms and signs? And of course, what are the things you really need to consider when it comes to treatment?
And we've got a lot of detailed medical information here. We've really gone deep into some pretty specialized texts. But, we don't need to get bogged down in all the nitty-gritty. We're going to distill it down to the really crucial points.
The things that will actually make a difference when you're in the clinic facing these cases. So just to give you a sense of where we're headed today, we're focusing on 4 main types of these tumors. We'll be looking at varices, lymphangioma, capillary hemangioma, and cavernous hemangioma. So a good mix there.
Yeah, it really covers the spectrum of what you're likely to encounter, both in kids and adults.
Okay, so let's jump right in. Let's start with orbital varices.
Right, good place to start.
Now, our sources describe these as being likely, hamartomatous formations, so basically a benign growth of thin-walled vessels that are often just like part of the normal circulation. But, and this is where it gets interesting, they can be linked to varices that you might also see on the eyelids and the conjunctiva.
Yeah, that's actually something to keep in mind. If you're examining a patient and you notice varices in those areas, it really should make you think, could there be an orbital varix as well?
Right. And while these varices can happen at any age, they can sometimes be acquired later in life, which can throw you off a bit. Maybe due to some other vascular problem or even after some kind of trauma.
That's a great point. Taking a thorough history becomes even more important in these cases, trying to understand what might have led to these vascular changes.
So how do these varices actually present? Well, the typical scenario is unilateral, meaning only one eye is affected, and they tend to show up in the upper nasal quadrant of the orbit.
Got it. And what are the actual signs? What should we be looking for in the exam room?
Well, the real giveaway seems to be this intermittent non-pulsatile proptosis. So the eye bulging forward, but it comes and goes, and there's no whooshing sound, like a bruit that you might hear with other vascular lesions.
Intermittent proptosis. Okay, that's interesting. Does anything trigger it, make it more noticeable?
Yeah, that's actually the key here. Anything that increases venous pressure can make that proptosis pop out more. So think about it. Things like coughing, straining, like when you do a Valsalva maneuver, even just being in a head-down position.
Wow, even simple things like that. So really that bedside clinical exam becomes crucial for suggesting this diagnosis.
Right. You can even try gently compressing the jugular veins and see if that makes the proptosis more prominent. Really helpful for making the diagnosis.
Okay, that makes sense. So let's say you suspect an orbital varix. What kind of imaging would you order to confirm?
Well, the sources mention a few options: MRI, MRV, CT, and ultrasound. They all have their pros and cons, but the key findings you're looking for are pretty similar. You want to see that lobulated mass, and it might show different levels of contrast enhancement.
Okay, I'm picturing that on an MRI. Anything else to watch out for?
Yeah, you should also look for those tiny calcifications within the veins called phleboliths. And sometimes you might even see some expansion of the bony orbit itself, particularly if this is happening in a younger patient.
Interesting. So we've talked about diagnosis, but as ophthalmologists, I think the main concern is always what can go wrong? What complications should we really be prepared for with these orbital varices?
Absolutely. And there are a few big ones to keep in mind. The most worrisome are acute orbital hemorrhage, thrombosis, and compression of the optic nerve.
Okay, those are serious. Let's break those down a bit. What would make you suspect an acute hemorrhage?
Well, think sudden onset of pain, increased proptosis, and maybe even changes in vision. It's an emergency situation.
Right, you need to act fast to try to control the bleeding and protect the vision. And what about thrombosis? How does that usually present?
Similar to hemorrhage, actually. You might see pain, proptosis that's gotten worse quickly, and of course, those vision changes are a big red flag.
Okay, so both of those could be pretty dramatic. And I guess optic nerve compression, that's another big worry with anything in the orbit.
Exactly. It can be gradual or sudden, and the key is to catch it early before there's permanent vision loss.
So those are the acute things. Are there any long-term complications we should be aware of?
Yeah, actually. One thing the sources mention is that over time you might see some atrophy of the fat around the eye. This can lead to an ophthalmos, where the eye kind of sinks back into the socket. And you might also notice a deepening of that superior sulcus, the groove above the eyelid.
Hmm. Okay, so these things can really have a range of effects, both in the short and long term. So when it comes to treating these orbital varices, what's the general approach?
Well, for small lesions that aren't causing any problems, observation is often the best course. But when you're thinking about surgical removal, well, things get a lot more complicated.
Right, I can imagine. You've got all those important structures right there in the orbit.
Exactly. And these varices, they're fragile, they bleed easily, and the optic nerve is so close by, it can be a really risky surgery.
So are there any situations where surgery would be considered, even with those risks?
Definitely. If you've got recurrent thrombosis, if the patient's in a lot of pain, if the proptosis is severe and causing problems, or, most importantly, if there's any sign of optic nerve compression.
So really, it's about weighing the risks and benefits carefully for each patient. Are there any special techniques that are used to try to make the surgery safer?
Yeah, the sources talk about things like embolization and using a CO2 laser. These can help control bleeding and make the surgery more precise.
All right, so that's a good overview of orbital varices. Now let's move on to another type of vascular tumor, lymphangioma.
Sounds good. Now, lymphangiomas, they're rare. They're also hamartomatous, just like varices, but they have this tendency to grow in a more diffuse way, kind of spreading out and infiltrating into the surrounding tissues.
So not as neatly contained, more like tentacles reaching out. That makes surgery tougher, I would imagine.
Exactly, and that's something we'll come back to. But, it's interesting. There's this idea that lymphangiomas and venous anomalies, like those varices we just talked about, might actually be different points on a spectrum of the same underlying condition.
Oh, that's fascinating. So you might have something that's more like a pure varix, something that's more like a pure lymphangioma, and then a whole range in between.
Right. They're calling these combined venous lymphatic malformations now, which makes you think if you see one, maybe you should be looking for signs of the other.
Makes sense. So how about the clinical presentation of lymphangiomas? What should we be looking for?
Well, they often show up in childhood, which is something important to keep in mind when you're seeing younger patients. And there's this unique feature. They can bleed internally, forming what they call chocolate cysts.
Chocolate cysts, that's a pretty descriptive term. So these cysts, are they permanent or can they go away on their own?
That's the cool part. They can actually regress spontaneously. Now, when you're trying to figure out what you're dealing with in a child with a possible lymphangioma, you've got to think about other things like orbital venous anomalies, the varices we talked about, and hemangiomas, which we'll get to later.
Right, those are all on the differential. And there's another thing to consider, isn't there? The possibility of problems beyond the orbit.
Yeah, good point. The sources mention that although it's rare, lymphangiomas can be associated with vascular malformations in the brain. So in some cases, you might want to consider further neurological evaluation.
Okay, so we need to think about the bigger picture, not just the eyes. Now, in terms of how these lymphangiomas actually affect the eyes, it seems like there's a distinction between anterior and posterior lesions.
You got it.
Mm.
So the anterior ones, those are the ones that are closer to the front of the eye. They often present as kind of soft, bluish masses, and they tend to be in that same upper nasal quadrant we talked about with varices.
Okay, so you might actually be able to see them pretty easily on exam. What about the posterior ones, the ones further back in the orbit?
Those can be trickier. You might see a gradual proptosis, but sometimes it can be more dramatic.
Dramatic in what way?
Well, they can bleed, and that bleeding can cause a sudden, painful increase in proptosis. And of course, like we said before, that puts the optic nerve at risk.
So those are the ones that can really sneak up on you, maybe even mimic something like an infection.
Exactly. And remember, these lymphangiomas can also involve the eyelids, the conjunctiva, and even in some rare cases, they can extend all the way back into the throat area, the oropharynx.
Wow, so they can be pretty extensive. All right, so we've talked about diagnosis. Now let's tackle the management of lymphangiomas. I'm guessing surgery is the main option.
It is, but there's good news and bad news when it comes to surgery. The good news is a lot of these lymphangiomas, they don't actually need any treatment, especially if they're not causing any vision problems.
So observation is often the best approach. That's reassuring, especially for parents who might be worried about their child needing a big surgery.
Right. But here's the bad news. If you do need to operate, completely removing a lymphangioma can be really, really hard.
Why is that? Is it because of their location?
It's partly the location, but the bigger problem is that they don't have a nice clear capsule, and they tend to grow into the surrounding tissues.
Like we said before, more like roots spreading out.
Exactly. So even if you try to get it all out, there's a good chance some of it will be left behind and it might grow back.
So what can you do in those cases? Just keep operating to remove what you can.
Sometimes, yes, you might have to do multiple surgeries to try to control the growth and prevent complications. And there's another tool that can be helpful for those chocolate cysts we talked about,
What's that?
the CO2 laser. It can be used to drain those cysts or debulk them, shrink them down, which can help relieve pressure on the surrounding structures.
Okay, so it's not always about trying to cure the lymphangioma. Sometimes it's about managing the symptoms and preventing complications. Now, I know we've got a lot of pediatric ophthalmologists listening, and I'm sure they see this next type of tumor all the time.
Yeah, you're talking about capillary hemangioma.
The classic childhood tumor.
It's the most common one in the orbit and the area around the eye, and it definitely pops up more in girls.
Yeah, and the thing with these capillary hemangiomas is they can be tiny and not cause any trouble at all. But sometimes they can grow into these big, disfiguring masses that can mess with vision and even cause problems in other parts of the body.
Yeah, it's a real spectrum of presentation. Now, the sources define these as being hamartomas, just like the other ones we talked about. But in this case, it's an overgrowth of those endothelial cells that line blood vessels.
So too many cells, but they're not cancerous, they're not malignant.
Exactly. But here's where it gets a bit more complex, especially for you guys who are focused on the eyes. When you've got a kid with a large capillary hemangioma or multiple ones, you have to think about the possibility that it might involve organs inside the body.
Okay, so it's not just a cosmetic issue in those cases. What kind of systemic problems can these cause?
Well, there's a condition called Kasabach-Merritt syndrome, which is really serious. It causes a really low platelet count, which can lead to bleeding problems.
Oh, wow, that's scary. And then you said heart problems too.
Yeah, in some cases, these large hemangiomas can put so much strain on the heart that it leads to high output cardiac failure. Basically, the heart's working overtime trying to pump blood through this extra tissue.
So if you're seeing a kid with a really big hemangioma, or several of them, it's probably a good idea to do some blood tests and maybe even an echocardiogram. Check the heart's function.
Absolutely. You want to make sure you're not missing any of these systemic issues. Now, just to put things in perspective, these capillary hemangiomas, they happen in about 5% of infants.
So not super rare, but not exactly common either.
Right. And there's another association to keep in mind, especially if you're seeing a baby with a large hemangioma on the face. They can sometimes be part of a syndrome called PACE syndrome.
PACE syndrome. Okay, another acronym to remember. What's that all about?
It stands for posterior fossa malformations, hemangiomas, arterial anomalies, cardiac defects, eye abnormalities, and sternal defects.
So a whole bunch of potential problems. And the eye abnormalities, what kind of things are we talking about there?
You can see things like optic nerve hyperplasia, colobomas, even microphthalmia, so definitely something to be aware of. Now, when it comes to diagnosing these capillary hemangiomas, parents usually notice them pretty early on, sometime in the first few months of life.
But you mentioned earlier that some are present at birth.
Yeah, about 30%. Now, even if a lesion looks like it's just on the surface, it's super important to make sure it's not extending deeper into the orbit.
Right, you don't want to underestimate the extent of these things. Now, there are those classic descriptions, the strawberry nevuses for the superficial ones.
Bright red, like a strawberry. And then for the deeper ones, the perceptal ones, those are more of a bluish or purplish color.
Got it. And these deeper ones, where are they typically located?
They often show up in the upper part of the eyelid, above the tarsal plate.
Okay, makes sense. Now, one thing I've noticed with these hemangiomas is that they seem to change size and color when the baby cries or strains.
Yep, that's because of the increased blood flow. But one thing that helps distinguish them from other vascular lesions is that they don't usually pulsate, and you don't usually hear a bruit.
So that can help narrow down the diagnosis. Now, what about those deeper orbital tumors, the ones that aren't visible on the surface? How do they present?
Well, the main thing you'll see is unilateral proptosis, just one eye bulging forward. And there might not be any skin discoloration, so it can be tricky to spot at first.
So you really need to have a high index of suspicion. Anything else that can clue you in?
Yeah, often you'll see the hemangioma involving the conjunctiva. either on the eyelid or in the fornix.
Okay, so that's a helpful sign. And you mentioned earlier that these kids often have hemangiomas in other parts of the body, too.
Exactly, that can be another clue. Now, when it comes to imaging, ultrasound is a good option for the superficial lesions, but for the deeper ones, or if you suspect more extensive involvement, you'll probably want to do an MRI or a CT scan.
Okay, and what are you looking for on those scans?
You're looking for that soft tissue mass, and you might see that the bony orbit is enlarged, even without any erosion of the bone itself.
Interesting. Now, one of the most important things to understand about these capillary hemangiomas is their natural history.
You're right, they have this very predictable pattern of growth and then regression.
So they grow rapidly for the first few months, and then they slowly start to shrink and disappear on their own.
Exactly. That rapid growth phase usually lasts about 3 to 6 months after you first notice the lesion. And then it starts to regress, and by the time the child is 3 years old, about 30% of them will have completely gone away.
By age 7, it's even more, around 75%. That's a really important point to emphasize to parents, to reassure them that these things often take care of themselves.
Absolutely. Now, there are times when you do need to treat them, even though they tend to go away on their own.
So when would you recommend treatment?
The main reason to treat is to prevent amblyopia.
Amblyopia, that's the lazy eye where the vision doesn't develop properly in one eye.
Yep. And these hemangiomas can cause amblyopia in a few different ways. They can induce astigmatism, they can create anisometropia, where the two eyes have different prescriptions, they can block the visual axis directly, or they can even cause strabismus.
So you got to be really vigilant about monitoring vision development in these kids.
Absolutely. Now, there are other reasons to treat besides amblyopia. Sometimes the hemangioma can cause so much disfigurement that it affects the child's self-esteem.
Okay, so there's a psychosocial aspect to consider as well.
Right. And then, of course, there's the risk of optic nerve compression or exposure keratopathy, where the cornea gets damaged because it's not being properly protected by the eyelids.
Got it. So there are a few different reasons why you might need to intervene. And the good news is there are a lot more treatment options available now than there used to be.
Definitely. The mainstays of treatment nowadays are beta blockers.
Beta blockers, the same medications used to treat high blood pressure and heart problems.
The very same. And they work wonders on these hemangiomas. You can use them orally, like propranolol, which is usually managed by a pediatrician, or you can use them topically, like timolol eye drops.
So why would you choose one over the other?
Well, oral propranolol can be very effective, but it does come with some potential side effects. Topical timolol is a good option for smaller, more superficial lesions, and it has fewer systemic side effects.
So it's a safer choice for many kids. What about steroids? Are those still used for hemangiomas?
They are, but they're not the first-line treatment anymore. You can inject steroids directly into the lesion, but there are some risks involved.
What kind of risks?
One of the big concerns is central retinal artery occlusion. It's rare, but it can cause permanent vision loss. And there are other potential side effects like skin changes, fat atrophy, and systemic effects from the steroids.
Okay, so you got to weigh those risks carefully. Are there any other ways to use steroids for these lesions?
Yeah, you can use high-potency steroid ointments directly on the eye, but those work more slowly. And then there are systemic steroids, which might be needed for large hemangiomas or if you need to shrink it quickly in a vision-threatening situation.
Got it. So beta blockers are first line, but steroids still have a role in certain cases. And I remember you mentioned laser therapy too.
Right. Lasers are a good option for those tiny superficial lesions, the ones that are less than 2 millimeters thick.
So really targeted treatment. And then there are those more heavy-hitting treatments like interferon and vincristine.
Those are reserved for the really tough cases, the ones that don't respond to anything else and are threatening vision.
Okay, so those are the last resort. And what about surgery? Is there ever a role for that with capillary hemangiomas?
Yeah, sometimes you might consider surgery for smaller lesions that are in their inactive phase, meaning they've stopped growing and are starting to involute. Or you might do surgery if the hemangioma is causing a lot of disfigurement or is putting pressure on the eye.
Right, so we've covered a lot of ground with capillary hemangiomas. Now, let's move on to the last type of tumor on our list today, cavernous hemangioma.
Okay, this one's interesting because it's mainly a tumor of adults.
Yeah, and it seems to be much more common in women.
Yep, about 70% of cases are in women. Now, what's really intriguing is that it might not be a true tumor at all.
What do you mean?
Well, some experts think it's actually a vascular malformation, kind of like a low-flow arteriovenous malformation.
Interesting. So it's more like a tangled mess of blood vessels than an actual growth. And that low flow thing, that explains why they tend to grow so slowly.
Exactly. Now, they most often show up in the lateral part of the orbit behind the globe, tucked in between the muscles.
Okay, so not right up front where you can easily see them.
Right. And if you were to look at one under a microscope, you'd see these vascular channels of all different sizes separated by these fibrous bands.
So it's like a honeycomb of blood vessels. Now, how do these cavernous hemangiomas present clinically? What kind of symptoms do patients typically have?
The most common symptom is slowly progressive unilateral proptosis. So the eye slowly bulges forward, usually just on one side.
Unilateral proptosis, got it. Any other telltale signs?
Yeah, when you examine the patient, you usually see axial proptosis, meaning the eye is pushed straight forward.
Okay, as opposed to being displaced up, down, or to the side.
Exactly. And you might also see some subtle changes in the back of the eye, like swelling of the optic disc or those folds in the choroid.
Interesting. Now, what about those lesions that are located at the very back of the orbit near the apex? Do they always cause proptosis?
Not necessarily. They can actually compress the optic nerve without causing much proptosis at all.
Oh, wow, that's tricky. So you might not see any obvious outward signs, but the vision could be affected.
Right. And you might even get some interesting visual symptoms, like transient blurring that comes and goes depending on where the patient is looking.
Almost like a mini blackout when they move their eyes in a certain direction.
Exactly. And sometimes the eye muscles might not move as smoothly as they should.
Okay, so there are a few subtle clues to look for. Now, how do you confirm the diagnosis? Is it imaging again?
Yep. CT and MRI are the go-to tests for these. They'll show that well-defined oval-shaped lesion, usually within the muscle cone, and it'll show this slow, gradual enhancement with contrast.
Okay, so the imaging findings are pretty characteristic. What about ultrasound? Is that useful for these?
It can be, especially if the lesion is located closer to the front of the orbit.
All right, so we've got our diagnosis. Now, the big question. How do you treat these cavernous hemangiomas?
Well, here's the good news. A lot of them are found by chance, maybe when the patient's getting imaging for some other reason. And if they're not causing any problems, you can often just leave them alone.
So observation is a valid option in many cases. But what about the ones that are causing symptoms, like proptosis or vision problems?
Those usually need to be surgically removed.
And how difficult is that surgery? I'm remembering you said earlier that lymphangiomas can be really hard to remove completely.
Yeah, but cavernous hemangiomas are different. They're usually much easier to deal with surgically
Why is that?
because they tend to be well encapsulated. They have this nice clear boundary, so you can usually shell them out pretty cleanly.
Okay, so that makes the surgery safer and more effective. So to wrap things up, let's go over some of the key takeaways for all of you ophthalmologists out there.
Good idea. Let's do a quick recap.
All right, starting with orbital varices. Remember, look for that intermittent proptosis that gets worse when venous pressure goes up. And be on the lookout for those acute complications like hemorrhage, thrombosis, and optic nerve compression.
Yep, those are the ones you don't want to miss. Now, for lymphangiomas, remember that they often show up in childhood, and those chocolate cysts can be a clue. And when you're thinking about treatment, remember that they can be really hard to remove completely because of their infiltrative nature.
Exactly. Moving on to capillary hemangiomas. They're the most common type in kids, and they have that characteristic pattern of growing rapidly and then shrinking on their own. The main goal of treatment is to prevent amblyopia, and beta blockers are the first-line treatment these days.
Right. And finally, for cavernous hemangiomas, those are mostly seen in adults, especially women. They cause a slow, progressive proptosis, and they're usually well encapsulated, making them easier to remove surgically.
So really, a lot of different presentations and management strategies to consider. But I think this deep dive has given everyone a good foundation for understanding these various orbital vascular tumors.
Absolutely. And hopefully it'll help you diagnose and manage these conditions more confidently and effectively.
That's the goal. Now, before we go, I want to leave you with one final thought. We've learned so much about these tumors in recent years, and our understanding of how they develop and behave is constantly evolving.
Yep. And with all the advancements in imaging and treatment, who knows what the future holds?
Exactly. So as you continue to care for patients with these conditions, keep learning, keep questioning, and keep pushing the boundaries of what's possible, because ultimately, it's all about improving outcomes for our patients.
Couldn't have said it better myself. Thanks for joining us for this deep dive, everyone. We'll see you next time.